So welcome everyone. Today's topic is cardio-oncology and is cancer linked to heart disease? And with that, I would just like to give you a brief introduction about myself. So I landed here in Winnipeg on December 13, 2016, where my eyelashes froze for the first time instantly in my life as soon as I got off the flight. Fast forward, I pursued a Bachelor's of Science honors degree here at the University of Manitoba in the Department of Biological Sciences with a major in biology and a minor in microbiology. My first ever exposure to research was in Dr. Steve Wired's lab. If you've done cell biology, you know Dr. Fly, that's how he likes to go by, in the summer of 2019 through Undergraduate Research Award. Again, highly recommend applying for any summer research award opportunities. They are very good for you to get experience in research. So in Dr. Wired's lab, I got my basic understanding of molecular biology techniques, including animal and plant DNA or RNA extraction. So DNA stands for deoxynucleic acid and RNA is ribonucleic acid. These are both part biological molecules that code genetics. Then I did quantitative reverse transcriptase polymerase chain reaction. Again, a gene product quantifying technique. Bioassays. Bioassays are just multi-day experiments with specific time points for data collection and some genome cloning. Then I continued in the fall of 2019 and 2020 and transformed my summer project into an honors project looking at species specificity of RNA interference, which is a gene knockdown technique in disease vector control. So I worked primarily with two mosquito species, Aedes aegypti and Aedes albopictus. Aedes aegypti is a disease vector control for a disease vector for West Nile virus, Q fever, dengue, malaria, while Aedes albopictus is a sister species that is currently invasive in Canada. Okay, and just a brief, so I'll just have the chat open too, so if you want to post any comments in the chat, I'm monitoring that. Okay, with that, then I graduated in past summer, so just this May 2021. And 3 days after my last class, I started with a summer studentship here at Cancer Care Manitoba in the cardiovascular imaging lab at St. Boniface Research Center, and became a graduate student in September, so just this fall 2021, and started my master's in physiology and pathophysiology in the same lab. Okay, so with that, I just want to focus on today's learning objectives. So today's seminar, after the seminar, you should be able to have some idea about the importance of research in academia. You will learn some basic heart failure terminology and develop the ability to differentiate between left versus right-sided heart failure. Then you will apply this newly attained knowledge to a novel case scenario during which you will learn to evaluate primary literature. And this will be in the form of group work. So you'll be learning teamwork and collaboration. And overall, today's seminar is supposed to give you the tools to perform self-directed learning, because that's what university is all about. Okay, so with that, I want everyone to get their annotations tool ready. Toby, please, if you could make sure that the participants can annotate. And once you have your annotation tools ready, please feel free to answer this question, which is, why should one get involved in research as a STEM major? And STEM stands for science, technology, engineering, mathematics. You could also write what is the importance of research in general. There are no wrong answers. I just want opinions here. So, okay. You don't have annotations. 10 people annotate yet. Let's see. No, okay. Let me see if I can. Okay, try now. Yep. Okay, sounds good. So feel free to write your opinions here? Also, if you don't feel comfortable writing on the board, you can also, I put them in the chat so that I can see your answers. Okay, so we are already getting some good answers here: to find novel solutions to problems, to gain experience, help give experience for future jobs related to your research, learn, practice techniques, like to apply knowledge that you've gained in class, analytical chemistry, love it. Science is advanced by research, love it, love it. Gain new knowledge. Okay, great. To discover more about the world around us. Yes. And to gain, yeah, make connections. That's great. Help people. Easy to understand. Learn about scientific literature. Learn about scientific methodology to help with global challenges. I love it. This is great. Great participation, everyone. So I'm gonna clear annotations for now. This is amazing. I love it. Yeah, so let's see. Okay, so thank you everyone for participating. Now you'll see what some of my opinions are about this. By the way, there were no right or wrong answers. These are just opinions, and you would see some of your answers reflected here. So research is science in action. So what you learn in your classroom, that's what research is in real world. Research is the essence of academia and universities. Research is why your universities exist. You might think that they actually exist to teach you, but that's not really the case. Teaching is more secondary to universities. Primary objective of universities is innovation through research. Research is fundamental to discovery and innovation. So latest example in this COVID-19 pandemic is the most fastest developed mRNA vaccine, the novel COVID-19 vaccine. Hashtag Pfizer gang here. Research helps reach other career goals. Like a lot of you mentioned, you can gain experience through research. You can learn what it's about, make it your passion, make it your hobby. And that's what you do for the rest of your life, right? You can become a professor in a particular field. You can go to industry. You can join other careers like forensics, medicine, become a scientist. These are all different careers that you can access through research. Okay, so with that, I would just like to move ahead. So how to implement your textbook-based class-focused learning into real world. So you'll see there's a transition in this seminar today where we'll go from going from classroom textbook learning to now coming into a lab and seeing how that all those Krebs cycle and biochem and chem that you memorize, like how does that really apply in the real world situation? So with that, I'll like to open the first polling quiz. Let me know if you can see it. Okay, so the polling question should be out, and it is how many of students here have done some lab or field work. If you can't see the polling question, feel free to also post in chat, but hopefully you can answer the polling question. I already see results, that's great. So some people have, that's looking good. I hope this seminar serves as motivation to do it. Yeah, okay. That's great. Keep the answers coming. I'll just check the chat in the meantime here. Okay, everything seems good here. So I'm just going to end poll. So it seems like there's an equal divide between, like similar divide between people who have done some previous research, people who have no experience, or people who are looking forward to doing some after today's seminar. So that's good to always know. With that, I just want to start with one type of research which is known as preclinical study or the basic science research. So at the core of all research is what's something called basic science research. It is primarily used to test scientific theories and hypotheses. It uses cell cultures, animal models, and constitutes the majority of preclinical studies. It allows for in vivo testing to increase safety in clinical trials. It forms the basis of medical treatments by informing clinical trials. It is a faster way to rule out unsuccessful treatments, and one can run multiple batches and test various permutation and combinations of what drug treatment might work, what might not, which to give first, which to give after. So there's like plenty of options that you can explore in basic science models. Also, there's less resource limitation. This also really helps test a broad and hefty data set. It is also more trial and error friendly. So like if you make mistakes, that's totally fine. You can just redo the experiment. Usually they're not that long. They're also not that costly. And it has a lesser degree of ethical implication. So, most like animal models can be invertebrates or vertebrates, even up until like mice or pigs. The ethical implications of your errors are still less severe than when you move into clinical research. Mind you, though, there are still ethics you have to do ethics courses when you whether you work with invertebrates, vertebrates, they will be specific to your animal model, but still the degree of ethical implications are less. And it is the fastest mode to rule out unsuccessful methods. The second fastest, which brings me to my question that what would be the fastest method? So any guesses, feel free to put it in chat. If basic science is the second fastest, what would be the fastest method of ruling out unsuccessful treatments? Let's see here. Any guesses? You can also raise hand. I got computer models. Yeah, you're on the right track. Well, we're talking about animal model simulation. Yeah, simulation. So mathematical modeling using computer algorithms is the fastest method of eliminating unsuccessful treatments, as it uses various mathematical algorithms to predict the success rate of your basic science experiments and help determine which permutation combination is going to be most effective way of testing your hypotheses. So you can put in all of your permutation and combinations in this algorithm. It will already assess, okay, you have this protocol and this is how you are going to do it. So depending on all the variables you've input in it, it will give out, okay, out of this is your success rate of permutation combination 1, 2, 3, 4, and so on and so forth. And then on an average, like scientists then only perform the first 4 and see which one works. So it really helps focus your treatment batches for your hypotheses, and resource prevention too. Some might even say, depending on your research, environment friendly. Okay, so with that, I just want to share a little bit about what type of preclinical study did I do. So during past summer, I was working in a preclinical setting with mice, investigating whether the use of nutraceutical flaxseed will work equivalently and synergistically with pharmaceutical drug Prindopril in the recovery from doxorubicin and trastuzumab mediated cardiotoxicity. So both doxorubicin and trastuzumab are chemotherapy drugs that are given to women with breast cancer. And we know they're very good against the cancer, but they have a higher risk of causing injury to the heart, known as cardiotoxicity. So to test that, I performed echocardiography, which is an ultrasound of the heart. And in the mice, and before and after I injected the mice with the chemotherapy drug, and then I collected the heart tissues and blood samples for analysis. So because breast cancer, so I see a question in chat, so did the mice react differently based on sex? Because breast cancer is only predominantly affects women, so we only use female mice. So you're already hitting on a limitation of the study or a methodology design where we are only assessing female mice. So we're not really looking at male mice, just because the incidence of breast cancer in biologically male mice is pretty low. So no, I would say they did not react differently based on sex because we only looked at female mice. Good question though. Okay. And with that, I just wanted to here share this video. Yeah, it's working. I hope you can see it. Very hazy because mice are very small. But here you can see the left ventricle in a mouse. So here you can see at the bottom the endocardium of the heart, and then the LV cavity, which is left ventricle cavity, both like when it's in systole as well as in diastole. I know it's going super fast, but systole would just be like when it's totally contracted, and diastole would be when it's like totally open. And you can see that the heart walls from each side is like contracting equally and is in sinus rhythm. Okay, and up next you'll see the longitudinal view of the previous video, which has been paused. So instead of looking at like cross-sectional view in form of a video, like a moving 2D video, now you're looking at something that's like almost like making that cross-sectional in a longitudinal panel and then paused. So here you can see like what the measurements that I took. So this is your left ventricle cavity. And then I calculated posterior wall thickness here, which is this distance between this, like the bottom till here. Then I did the intraventricular septum up top. So that would be your septum between the two ventricles. Remember, we are only looking at left ventricle here. Then I looked at the left ventricle internal diameter so the small d just means diastole, and then the small s means during systole. So I calculated during diastole and then during systole, and then I calculated heart rate here. Then by inputting all these numbers into a formula, I calculated ejection fraction. Not really me, the computer did it, but you know, I did all the numbers. So, and then I'll teach you what ejection fraction is in a bit. Yeah, so what kind of device did I take to take these videos? So that would be the echocardiogram. So this is, you're looking at an echocardiogram right now. How did so there are different, this like the lengths are calculated just by the inbuilt computer program. So I just have to drag the pointer from like one end to another and kind of draws a line and throws out a number. Whereas ejection fraction, the computer has like different formulas for what type of calculation you want to do for the ejection fraction, and that spits out an ejection fraction. What is an ECG? Explain the device a bit more that you used for measuring. So an echocardiogram is an ultrasound of your heart. So in this case, I am doing just like if anybody has ever gotten your ECG done, any ultrasound done in general, they take a probe, they put a jelly on top and it feels kind of cold, and then they just like put it on your organ. So instead of like taking an ultrasound of a belly or of an artery, we are taking an ultrasound of your heart. So we take similar probe, it's a little machine, and you put it on the heart. What does ejection fraction measure? I will get back, I'll come to it now. So just hold your horses there. I'll be explaining that in more detail later. Okay, any more questions before I go forward? Everybody good? Okay, so since I'm not seeing any more questions, I'll keep going. So this was the basic science study. So now as part of my master's, I moved on towards the clinical setting. So now I had already tested this in mice, and now in my master's in the fall, I started looking at my project. So the research study that I'm looking at as a master's student is called Can Flax milk prevent broken hearts in women with breast cancer? Okay, so now everyone, once again, another cool activity coming up. But before we do that activity, I have more polling questions for you. So let me start the poll here once again. Okay, so how many students here have done first year human anatomy? So yeah, if you can, okay, quite a few of you, that's great. Okay, some have not done. Okay, some have done some plant or animal anatomy. That's good enough. Okay. Okay, so again, it's similar between people who have done some like who have done human anatomy and who have not, and then slightly under for people who have done some plant or animal anatomy. So that's good enough. I have yet another question for you guys that gives me a good idea of where you guys stand in your understanding. So how many people have done some form of dissection? So sheep or pig heart dissection? It's okay. In like high school, I've heard like some people have done frog hearts in high school. So if you've done any, okay, some people are scared of the blood too. That's okay. I've been scared before of blood. Yeah, pig heart. A lot of you have done pig heart. Cow heart, yeah. Other organs count too. I was more curious about the heart because today's seminar is focused on heart. Mice, yeah, a lot of you have done mice and frogs. That's great. Yeah, someone has done lungs from cow. Yeah, that's great. Yeah. Brain, okay, yeah, that's good. Yeah, good. Okay, so seems like good chunk of you have a good sense of dissections and are not afraid of blood. That's great. And with that, I have an annotation activity. So I just want you to get ready. So I hope your dissections help you out because we're going to do some labeling. Okay, so let's use stamping tool. So there's a stamping tool in your annotations, and let's use hearts. Okay, because this is a cardiology-based seminar. So everybody pick the heart stamping tool, and I want you to, first let me orient you. Okay, so this is a human heart, and we are looking at the front of the heart in the anatomical position. So everybody knows the anatomical position, the right and left switches, yeah? Okay, so we're looking at the anterior view, which is called the front of the heart. Okay, so let's get ready. So I want everyone to annotate the superior vena cava. Where is the superior vena cava? Oh my goodness, you guys got it on spot. That's great. Okay, let's clear that. Move on. Okay, another one. Where is the right atrium? Ooh. Okay, some people are hitting it. Most of you are slightly off, but that's okay. That is okay. Okay, so since most people are slightly off, I'm gonna clear. So please stop stamping now. Stop stamping. Everybody good. Okay. And now I'm gonna tell you where the right atrium is. So the right atrium is right here. This is your right atrium. Okay. Good job though, guys. Okay, let's keep doing this. Where is the pulmonary artery? Come on, guys. Yes, good job. That is the pulmonary artery. Good job. Okay, so let's clear. Yeah, you got it. Okay, and let's move on. Where is the right ventricle? Where is the right ventricle? Yes, that is the right ventricle. So yeah, you guys just got confused between yeah, that's right. That's the right ventricle. Great job. Okay, so I'm gonna clear now. Okay, where is the left ventricle? Where is the left ventricle? Yes, that is the left ventricle. Not that high, not that high. Slightly, yeah, where most people are. Most people got it right. Okay, okay, good job. Okay, where is the left atrium? Where's the left atrium? Yes, that's your left atrium. Okay, great job, guys. You guys are like natural born scientists. This is great. I love it. And now can everybody put a nice like stamp on the interventricular septum? Interventricular, yes, nice. It's nice in a line. I love it. Great job, guys. Great job. Okay, now is the trick one. We'll see who gets this one. So ductus arteriosus. Where is the ductus arteriosus? And can someone post in the chat, what is ductus arteriosus? What is ductus arteriosus? So I don't see any comments in chat yet. I also don't see anybody getting it, the figure, interestingly. Where is ductus intros? Okay, so I got a comment in the chat, so that's correct. It's the shunt between the pulmonary artery and aorta. Oh, yes, good job, good job. Now people got it after the definition, yes. So I'm just gonna clear it. Great participation, guys. And I'm just gonna, just to confirm with everybody, this right here is your ductus arteriosus. Because remember, we marked this part as pulmonary artery, and the part that the probe is entering, so right up here, this is your aorta. So like your aorta like kind of arches and goes behind. So that's your aorta, and then ductus arteriosus is joining between the pulmonary artery and aorta. Of course, in adults, it's supposed to be closed. It provides a shunt in fetus. Okay, sounds good. Okay, great job, great participation, everybody. Thank you. I loved it. So now let's look at some of more heart health assessment-based terminology. So now I'll just let you know what the ejection fraction is. So it's the fraction of blood which is ejected from the end diastolic volume. So remember, when your ventricles relax, they start getting filled with blood. And at the end of your diastole, when they eject, so what fraction of that end diastolic volume blood gets ejected out of the ventricles and into their respective pathways? That's called ejection fraction. It is a measurement of heart failure, and heart failure is classified into 3 categories: mild, moderate, and severe, based on your percent ejection fraction. So a mild heart failure is has an ejection fraction of 45 to 55%. In moderate, you have an ejection fraction of 35 to 45%. And in severe, you have an ejection fraction below 35%, right? And in a normal human, the ejection fraction is 60% and above. Okay, so I'm just gonna clear the annotations. Sorry, guys. I just find them distracting. And then the normal heart range in mice is 700 to 800 beats per minute. And in humans, you almost know it's 60 to 80 beats per minute. That's the resting heart rate for humans, and resting heart rate for mice as well. Now, can someone guess, and please post in chat, what is the resting heart rate of a whale? The biggest mammal on Earth. What's the resting heart rate of a whale? Guess. It's okay. Don't Google. Guess. I want guess. Beats per minute. Yes. Okay, I'm getting 20. So I'm getting 5.5. I don't know about that. 10, 6, 5, 15, 3, 30. Okay, 18. So lots of guesses. I would say, yeah, 3 to 5 beats. Yes, it's about 4 to 5 beats. Like that's the closest answer. So great job, everyone. Yeah, the largest mammal, they have a 60-ton weight and then like a 1-ton heart. So that's a very powerful heart. So it only has to beat 4 to 5 beats per minute. So someone asked me, why do mice have such a high heart rate? So heart rate has to do with two things, your metabolic rate as well as your body size. So the bigger the animal, the bigger your heart becomes and the stronger it becomes. So then it has to beat less. For example, in a whale, mice are smaller and they have a very high metabolic rate. So their heart is also small and not so strong. So it has to beat rapidly within 1 minute. Why does the heart beat slower? It just has to do the same reasoning. So the metabolic rate and body size. So remember, the bigger your muscles are, the less they have to work just in general. So heart is a muscle, and essentially that's why bigger animals have lower heart rate. Why do large animals have slower metabolism? Not necessarily slower in all large animals. I would say mostly colder climate animals have a slower metabolism. It mostly has to do with size too. Yeah, and how much you're moving per se. But there are two independent factors that both contribute to heart size. So the size of the animal and metabolic activity of the animal. Okay. Do marine mammals have slower beats per minute in general? Depends what you're comparing them to. If you are comparing marine mammals with other marine mammals, again, it's a size bet. If you're comparing marine mammals with fishes, I don't think that's a fair comparison because remember, fishes have a 2-chamber heart, not really a 4-chamber heart. So it will depend from species to species. So why having the ejection fraction decreasing, the heart failure gets severe? Yes, so remember ejection fraction is your measurement of how good the heart is pumping, right? So as your ejection fraction percent decreases, that indicates that the heart is not pumping as efficiently, right? So it's not ejecting as much blood out as it would if the number was higher. So higher the ejection fraction, the better the pumping function of the heart. So I hope that clears the question. Okay, any more questions? Any more burning questions before I move on? Okay, I don't see any, so I'm gonna keep going. I will also stay here for like 10-15 minutes after if you have some burning questions. Okay, so let's move on with our heart failure terminology. So we have left versus right-sided heart failures and how to distinguish them. So in left-sided heart failure, your left-sided output is reduced, obviously. Blood starts backing up in your respiratory vasculature, so that would be your lungs, and it results in pulmonary edema. So edema is just like your fluid leaks through your capillaries and starts filling your interstitial spaces. That kind of causes like a feeling of drowning when you are not really drowning, but you start like getting heavy, like your breathing rate increases and you start feeling like you're suffocating. And this is called congestive heart failure. Also, kidney blood flow gets reduced, which results in fluid retention in your body. So the person will kind of complain of bloating, right? And then moving on to the right-sided heart failures. In this case, obviously, the right-sided output gets reduced. It backs up into your systemic venous systems and results in ascites or peripheral edema. So you get a swelling in your extremities. And in general, left-sided heart failure tends to be more serious than right-sided, just because your left side of the heart pumps to the entire body and you get more compromised with left-sided heart failure when compared to right-sided heart failure. However, prolonged whether you have left-sided or right-sided heart failure, prolonged left-sided heart failure can ultimately lead to right-sided heart failure, and prolonged right-sided heart failure can ultimately lead to left-sided heart failure. So these are initial differentiations, and then with chronic disease, they just become one, essentially. Okay, I have, does congestive heart failure act quickly, or does it slowly get worse over time? Depends how severe your heart failure is again. So it will be quickly if your ejection fraction is more reduced. Though in general, heart failure is considered a chronic disease. So you technically never get cured, kind of like this diabetes. You have to learn to live with it. But definitely your symptoms can be so minimized that you don't really feel like you are living with heart failure. So if a person is consistently having water retention, does that mean that there's something that a doctor would have to take a closer look at in person? Of course, yes. So bloating can happen because of gastric reasons, cardiac reasons, like all types of reasons. So in general, if it's a persistent bloating, but what we mean by bloating in like heart failure context, it means like a gain of 2 to 3 kgs in one day. So in 24 hours, 24 to 48 hours, you've gained like 2 to 3 kgs. That's kind of what in cardiac terms we mean by fluid retention in the body. How long does it typically take before it merges into two-sided heart failure? I'm not sure if I understand the question. Do you mean how long does it take before your essentially like the fluid backs up from left side to the right side? That depends on various like lifestyle factors and whether you got treatment and you were taking your medications to begin with, because once the medications kick in and people like say start exercising, taking care of diet and everything, technically that situation can just never occur. So it's not necessary that that would happen. That's just if it gets ignored. Does heart failure kill a lot of people, or can people live with it for a long time? Both, actually. So heart failure is actually the leading cause of mortality worldwide, killing 100,000 people annually. So it does kill a lot of people, and actually, sadly, it is one of the diseases that hasn't really progressed in terms of treatment options. However, at the same time, if the lifestyle factors play a major role for people. So if people themselves try to change their lifestyle despite the diagnosis, they can totally like be in remission and live a normal, healthy life for like an average individual. Is there a point where medication lifestyle changes no longer help? Definitely there is, usually age related, but there is. Which side of the heart usually starts or is more often as the person ages? Again, depends. The age correlation in heart failure isn't as strong as certain other correlative factors, so depends. Yes, cholesterol level have everything to do with heart failure. They cause something called coronary artery disease. You don't want that. Do genetics? Yes, they do play a larger factor. Yes. Okay. So I just got a text that we have to be mindful of time. So we'll keep moving, but thank you for your questions. So once again, we know chemotherapy causes heart failure. It's very efficient in reducing the breast cancer, but has a significant risk of cardiotoxicity, which affects 1 in 4 women. And then now we are going to look at the potential mechanisms of doxorubicin and trastuzumab mediated cardiotoxicity, which include oxidative stress and upregulation of inflammatory pathways. And cardio-oncology in general is an upcoming field which is responsible for prevention, diagnosis, and management of chemotherapy-induced cardiotoxicity. So now let's look at the pathways quickly. So trastuzumab is a monoclonal antibody against HER2 receptor. HER2 stands for human epidermal growth receptor. It's just a peptide receptor, which is overexpressed in 25 to 50% of breast cancer cells. It increases the apoptosis in myocytes, so that's the cardiac cells, owing to its anti-HER dimerization properties. And overall, it also upregulates the renin and angiotensin system. Anybody heard of it? It's called ROS, which regulates blood pressure. So it can cause high blood pressure. Right? Doxorubicin, on the other hand, it induces cardiac dysfunction in a dose-dependent manner. So higher the doxorubicin dose, the higher the cardiac dysfunction. Doxorubicin works by initiating DNA cross-linking and altering DNA binding. It inhibits topoisomerase 2 function, therefore preventing proper DNA replication. It causes histone eviction via alkylation, so that's addition of methyl groups on your histone proteins, which are like DNA binding proteins, and ultimately leads to cardiac membrane damage. This activates reactive oxygen species like superoxide and peroxide with oxygen-free radicals, and overall, doxorubicin decreases the endogenous antioxidant defense mechanism of the heart cells. So they're kind of very defenseless against this drug. Fun fact, this drug is called the red devil in the oncology world because it tends to kill you. So with this, I would like to start with the case scenario, which is the part of exercise for today. Just to provide some context in real life, I want everyone to imagine being a healthcare provider, attending to a 32-year-old woman here. She's mother of 3 toddlers who has been diagnosed with left-sided breast cancer on a snowy day in January 2021. Like many, she proceeded to receive a multimodal treatment plan, including mastectomy, which is removal of the breast tissue, radiation, and classical anthracycline-based chemotherapy. She was elated to be told by her oncologist that she was finally in remission. However, to her dismay, only 1 month later, she started to develop a whole range of new worrisome symptoms, including shortness of breath and peripheral leg swelling. After being referred to a cardiology team, she was given the grim diagnosis of heart failure. So now let's look at her echocardiograph once again, which is the ultrasound of her heart. So you can see this echocardiogram is taken in an apical 4-chamber view. And you can see both like at the baseline and the 4-month follow-up, which is after the chemotherapy administration. Here you can see left atrium, left ventricle, right atrium, right ventricle in both of these echocardiograms. The baseline echocardiogram represents normal wall thickness and contractility. Therefore, the left ventricle ejection fraction is above 60%. However, if you look at the right here, the contractility of the heart has been compromised, which is represented by the drastic decrease in left ventricle ejection fraction being less than 20%. So once again, the echocardiogram, which is the ultrasound of the heart, provides you detailed information such as structure of individual parts of the heart, such as walls, you can see the walls, chamber size, walls, like mitral valve and tricuspid valve, as well as you can see chamber dimensions. So here on the right, you can see the chamber is kind of dilated here. This is known as the condition of hypertrophy. So your left ventricle is enlarged. You can also see the direction of blood flow with another program called flow cytometry, and contractility of heart. So contractility is the ability of a single cardiac cell to stretch. So kind of like a rubber band. How stretchy is the rubber band? So in this case, how stretchy is the cardiac cell? And ejection fraction. So any questions so far? Okay, so I don't see any questions. So we will go into our group work. So again, everybody, I want you to, when you go in your breakout rooms, just introduce yourself, tell everyone what you're studying, and then I want everyone to troubleshoot these questions, and I can post these in chat. So what degree of heart failure is the patient in the previous scenario suffering with? What are the risk factors of developing heart failure? Given their symptoms, does the patient have left-sided or right-sided heart failure? What standard medications would a healthcare provider prescribe? And just a bonus question that if the medications fail, what are her options? The bonus question you would only do if you're done with the first 4 questions, and it's not necessary to do. I would also recommend a divide and conquer approach. So I want each member of the group severe, given that the ejection fraction was below 21% in the previous echocardiogram. What are the risk factors of developing heart failure? So we sort of went over it when I was asking your question. So it's obesity, coronary artery disease, smoking, as well as hypertension, which is age-related hypertension. Okay. And then the next one was differentiating between left versus right heart failure. So for this, you could do a chest X-ray. So remember, one of the symptoms was pulmonary edema, which is fluid in your lungs, and this was for right-sided heart failure. So if you see a clear chest X-ray, that means it's not right-sided heart failure, so probably left-sided heart failure. If you see like a white blown chest X-ray, which means fluid in the lungs, this means it's a right-sided heart failure, right? And remember, this participant, it wasn't the case that the fluid built up in the chest. It was in their periphery. So they would have something called pitting edema, which you can see in this photo. So you would do something called a cap refill. So you would press their leg for a while, and usually it should fill up in 5 seconds or less. But for this person, it would stay way longer than that. And with this, you would conclude that it is left-sided heart failure in general. I hope people were able to find at least some medications. There's quite a few of them. You could use diuretics, they decrease blood volume. You could use ACE inhibitors, they vasodilate, therefore decrease the afterload on the lung, on the heart. You could use ARBs. They also vasodilate and increase afterload. And beta blockers, they decrease blood pressure. So I saw some of the groups discussing beta blockers. Some examples are carvedilol and metoprolol. You could use digoxin or digitalis. This increases the contractility, which is the stretchiness of the heart cell. And in the end, you can use aldosterone inhibitors, which prevents salt or water retention in your body. And I don't know if anybody got a chance to get to the bonus question, which was just that if medications fail, what are her options? And those are basically more invasive techniques like valve replacement and heart transplant. And with that, I conclude today's seminar. Thank you, everyone.